Hello everyone, welcome back to my channel Microbiology Simplified. I am your guide and mentor Dr. Amit Kumar Singh. In this video of PYQ series, I will be discussing about pseudomembranous colitis. And this is a very important topic because several questions has been asked in various PG examination. And if you have a superficial knowledge in this topic, you may not be able to answer those questions. So that's why I go through this video from start to the end, and I have discussed all the detail which is required to answer all the questions from this topic. So let's start with the video. So the MCQ which was asked is about a 50-year-old man who was hospitalized for cellulitis on his left leg for last 3 days, and he was prescribed clindamycin antibiotic for treatment. After 3 days of discharge, he developed diarrhea and abdominal pain, and he visited the hospital again with fever. Blood reports revealed a hemoglobin level of 11 gram per deciliter, WBC count of 16,000 per millimeter cube, and CRP of 150 milligram per liter. So what is the most likely etiological agent? So what is this case? This case, if you see that initially the patient was hospitalized for cellulitis, and later on after the antibiotic treatment he develops diarrhea and abdominal pain. And also if you see, the important clue to the diagnosis is the WBC count, which is increased, elevated. So what it leads to? So basically, as I told you, it is the diarrhea develops after the treatment of antibiotic or antibiotic intake. So it is a case of antibiotic associated diarrhea. Okay, antibiotic associated diarrhea. And also, as I told you, this is a clue, this WBC count. So it is clue to which disease. So for that, let's see the option. The option A, norovirus and rotavirus, these are known to cause diarrhea, but then these are not associated with antibiotic associated diarrhea. So these two are not correct. The E. coli is also known to cause diarrhea, but again it is not associated with antibiotic intake. The only option is Clostridium difficile here. But yes, obviously Clostridium difficile is not the only organism which is associated with antibiotic associated diarrhea. But then this WBC count, increased WBC count, is a clue to Clostridium difficile infection. So that's why the answer to this question is Clostridium difficile. But then the question may change, the options may change, everything may change because this is an important topic. So we'll go into the detail and we'll see that what are the important points which you should remember to answer the question from this topic. So let's start. So the disease which is caused by Clostridium difficile is called as Clostridium difficile associated diarrhea. In short, we call it CDAD. Or we can also call it Clostridium difficile infection. Okay. And it usually occurs after 3 to 5 days of antibiotic treatment, or it may occur 2 to 10 weeks after the treatment of the antibiotic has stopped. Okay, so either of these can be taken as for the duration of occurrence of the infection. And it is acquired exogenously. Okay, and most often it is acquired from the healthcare settings such as hospital or nursing home. Okay. And the antibiotic which are commonly associated, so one point you remember that all the antibiotics may develop Clostridium difficile infection. Even the antibiotic which is used for treatment of this condition, vancomycin, may develop CDI. Okay, but then there are certain antibiotics which has been found to be commonly associated are clindamycin, ampicillin, cephalosporin second and third generation, which includes cefotaxime, ceftriaxone, ceftazidime, and ceforaxime, and fluoroquinolones. So this fluoroquinolones has found to be associated recently only, and it includes ciprofloxacin, levofloxacin, and moxifloxacin. And the mnemonic which you can use to remember this is CAC fluor, CAC fluor. Okay, CAC fluor is associated with CDAD. Okay, and this C is clindamycin, ampicillin, and cephalosporin, and fluor is for fluoroquinolone. So remember it like this. Okay. And the pathogenesis of this disease is toxin mediated. And what toxin is produced? So it produces, this Clostridium difficile produces two exotoxins, toxin A and toxin B. And this toxin A is a potent enterotoxin, okay, and this toxin B is a cytotoxin. And the receptor for toxin A is glycoprotein, whereas for toxin B it is not yet known. But then the mechanism of action for both of them is glucosylation of rho protein, and this rho protein is basically a GTP binding protein, okay, GTP binding protein. So the glucosylation of this protein leads to alteration of actin cytoskeleton of the cell, and ultimately it has cytotoxic effect on the cell and leads to cell death. So this is the pathogenesis or the action of toxin. And what it leads to? It leads to pseudomembranous colitis, and this is the clinical entity of Clostridium difficile infection, okay. And this pseudomembranous colitis is confined to colonic mucosa. And what we will see, initially we will see 1 to 2 mm of whitish yellow plaques, and in between these plaques the intervening mucosa is normal, okay, and this plaques later coalesces with each other to form larger plaques and ultimately form a confluent over the entire colon, okay. So this confluent over the entire colon is known as pseudomembrane. If you see here in this image, you can see the whitish yellowish plaque and the normal intervening mucosa, and also you can see the confluent over the colon wall, and this confluent is basically pseudomembrane. And this pseudomembrane is made up of, it consists of necrotic leukocytes, fibrin, mucus and cellular debris, okay. So this pseudomembrane is made up of leukocyte, fibrin, mucus and cellular debris, okay, remember this. Now see the pathogenesis model for Clostridium difficile. So this Clostridium difficile, the stages for the development of this infection is of 3 stage or 3 event. The first event is exposure to antimicrobial. So this is the first event in development of CDI. The second event is acquisition of Clostridium difficile, toxigenic Clostridium difficile. This is the second event. And the third event is the host anamnestic response, anamnestic IgG antibody response against the toxin A produced by Clostridium difficile. This host anamnestic response, if it develops, then the patient will become asymptomatic carrier, okay. And if this host antibody response does not develop or fails to develop, it leads to Clostridium difficile infection. So this host anamnestic response development is the third event, and it will decide whether the patient will develop the disease or become an asymptomatic carrier, okay. Now the clinical feature, if you see, the presentation which is most commonly seen in case of Clostridium difficile associated diarrhea is obviously diarrhea, and the stool is never grossly bloody. So it is not bloody diarrhea, it is either soft and unformed stool, or it may be watery or mucoid stool. So it is never grossly bloody, it may be soft and unformed to watery or mucoid, okay. And this diarrhea is the most common presentation. Apart from that, we can also see fever, abdominal pain and leukocytosis. This unexplained if the patient is presented with unexplained leukocytosis with soft and unformed stool, in which WBC count is more than 15,000, this is an important clue to CDI, as I told you during the discussion of the question. So unexplained leukocytosis with WBC count more than 15,000 is a clue to CDI. And those patients who have got unexplained leukocytosis are at high risk of development of complications such as toxic megacolon and sepsis, okay. So remember this leukocytosis is clue to CDI, and it is a risk factor for development of complications such as toxic megacolon and sepsis. And the diagnosis is based on the combination of clinical criteria. And what are those? Those are diarrhea in which 3 or more unformed stool per 24 hour for more than equal to 2 days with no other recognized cause of diarrhea. That means no other cause of diarrhea is recognized if the patient is presented with 3 or more unformed stool for per 24 hour for more than equal to 2 days. Then it may be considered as one of the clinical criteria for diagnosing CDI. Second is glutamate dehydrogenase positivity. This is an enzyme produced by Clostridium difficile and it is used for screening. Why I am saying screening? Because it will not be able to differentiate between toxigenic and non-toxigenic Clostridium difficile. So that is why it is used as screening test for Clostridium difficile infection. So how to confirm? The confirmation is done by detection of toxin A and B in the stool by PCR or ELISA, or by detection of the toxin producing Clostridium difficile in the stool by PCR or by culture on a medium called a CCFA, which is basically a selective medium for Clostridium difficile, and it is cycloserine cephaloxytin fructose agar. And the last is visualization of pseudomembrane in colon. But it is seen in approximately 50% patient with positive blood culture and positive test for toxins. But then if this pseudomembrane is not visualized, we cannot rule out CDI. Does not rule out CDI. Okay. So remember this, negative pseudomembrane does not rule out CDI. And for the treatment, the first step is discontinuation of ongoing antimicrobial administration, obviously, and the second, we can use antibiotics such as oral fidaxomicin or vancomycin. This is the first line of treatment and it should be given for at least 10 days. Okay. And if suppose if oral fidaxomicin or vancomycin is not available, then in case of mild to moderate CDI, we can use oral metronidazole if it is not available. Okay, so this is all about Clostridium difficile infection. Now the next question which was asked in the same topic is, a broad spectrum antibiotic was prescribed to patient currently is experiencing recurrent diarrhea. Which of the following statement about the infection caused by Clostridium difficile is not correct? So if you remember, I told you it is toxin mediated. The toxin is A and B toxin. Pseudomembrane is consist of leukocyte, fibrin, mucus and cellular debris. This is also correct. IgM-SA is used to confirm the diagnosis. No. To confirm the diagnosis, what we need to do? Either detection of toxin or toxin producing Clostridium difficile. Okay. So this is for the confirmation. IgM-SA cannot confirm the disease. And oral fidaxomicin is used for treatment. Yes, this is also correct. So not correct option is IgM-SA. Okay. Which of the following investigation is considered to be most effective for diagnosing Clostridium difficile infection? Option A is glutamate dehydrogenase and toxin assay, glutamate dehydrogenase assay, aerobic culture of a stool, none of the above. So see, this aerobic culture of a stool is absolutely incorrect because the bacteria is anaerobe. So this is not correct. Now either glutamate dehydrogenase or glutamate dehydrogenase along with toxin assay. So as I told you, glutamate dehydrogenase is a screening assay. So it will not be able to differentiate whether the organism is toxinic or non-toxinic. However, this toxin assay will be able to distinguish between toxigenic and non-toxinic. So this is confirmatory method. So obviously a combination of screening and confirmatory is always the most effective method for diagnosing the disease. So this is the correct answer. So I hope this video will be helpful to you, and I promise that if you'll go through this video and make your own notes and revise it frequently, you will be able to answer all the questions from this topic from this content itself. Okay, so all the best, take care.